It is pretty hot. So we're going to talk about heat-related emergencies. So if you saw the news yesterday, you would have seen this boy. He's a 16-year-old boy, schoolboy from Ampara, who collapsed and died during a marathon. Last year, we had several cases similar to this. People working outside, some exerting themselves. A couple of years ago, closer to home around Kandy, there was a schoolboy who, a rugby player actually, doing a run from Kandy to Pallikale, again collapsed and died. If we look at the last 24 hours, the past 24 hours, the hottest temperature in the country was recorded in Kurunegala. The temperature was 37.1. So today we'll talk about heat-related illnesses, which is a spectrum of diseases ranging from mild to moderate and culminating in a severe form of emergency called heat stroke. So the minor heat illnesses, you don't really have to do much. You just have to know these things. Heat cramps, heat edema, heat rashes, even heat syncope and heat stress. Then it's a continuum. So then this heat syncope and all can progress into heat exhaustion, which can progress into a heat stroke. The most common thing in the emergency department related to heat would be heat exhaustion. So to begin with, I'd like to take your attention back to a bit of pathophysiology. We all know our temperature, body temperature is regulated in the hypothalamus, and the cutaneous receptors give the information. We have a core body temperature, which is slightly higher than the skin temperature. This temperature gradient actually helps with the heat dissipation. So we, as humans, we've got 4 mechanisms to get rid of excess heat: conduction, convection, evaporation, and radiation. Environmental temperature of 35 degrees is the critical point. Now, when our environment is more than 35 degrees, I don't refer to the number 35 as measured in the thermometer. It is what it feels like. So if you just Google up the temperature in Sri Lanka, this is 7 o'clock this morning. So the actual temperature was 26, but it felt like 35. So the temperature, the temperature you feel is the critical temperature that we want to refer to when you consider heat-related emergencies. If our core body temperature goes above 42 degrees centigrade for more than 45 minutes, we are at risk of heat stroke. When the core body temperature goes up, the skin blood flow goes up, there's peripheral vasodilatation, the cardiac output goes out, sweat production goes up, and we initiate behavioral responses. This is if we have good thermoregulation. But unfortunately, if our thermoregulatory mechanisms are inadequate, if we are ill, with increasing core body temperature, you would see reduced blood flow to the skin, the muscles, and the brain. Our metabolism accelerates. We develop a systemic inflammatory response-like syndrome. And also, we can develop a coagulopathy. So, heat-related emergencies, when we talk about these heat-related emergencies, we have to consider few facts. There are some individual facts. As individuals, we could be susceptible to heat-related illnesses. Like if you're very old or if you're very young, when you have other medical conditions, if you're on medications, if you're pregnant, if you've got social isolation, if you can't move, if you've got injuries like spinal injuries, then there are socio-cultural factors and heat, the actual heat exposure. What is the ambient temperature? What is the humidity? And is there anything that amplifies the heat? Like urbanization, you have little islands like covered with lot of concrete buildings, becomes an island with heat amplification. Then there are occupational exposures. Few years ago, during the height of COVID, most of us who worked in the emergency departments, for the whole duration of your shift, you would wear the full PPE kit. And you know how hot you get. So there are other occupations like this, like factory workers. Then you have lack of access to cooling at home, particularly in our setup with the ever increasing electricity bill. I mean, we can't afford to put air conditioning all the time. So heat injury itself, we can divide, we can classify as exertional heat injury, which is usually related to physical activity, but not necessarily. Exertional heat injury can occur even at normal ambient temperatures, like it doesn't need to be hot environments, but certainly if you're exercising, if you're exerting in a hot environment, the susceptibility to get heat injury is more. Then you have your classic form of heat injury, where vulnerable individuals develop heat-related illnesses due to high ambient temperatures. Who are these vulnerable groups? Just like I mentioned before, the extremes of age, people who take antipsychotics, amphetamines, anticholinergics, burns victims, victims with spinal injuries, those who have chronic disorders like autonomic disorders where you can't sweat, and hydrosis, people with endocrine diseases and skin diseases, those of us who got psychological impairments and we cannot initiate our behavioral responses, and then socioeconomic limitations, obese people, and people who are more likely to be dehydrated, especially children, and also those of us who are on diuretics. Now, as doctors, we prescribe a lot of medications. So, what are these medications that can actually increase the risk of heat-related injuries, particularly during these times? So, alcohol is one. Amphetamines, which is a substance of abuse, we increasingly see this in our practice now. Anticholinergics, antihistamines, because that can cause peripheral vasoconstriction, and it sort of reduces your heat dissipation from the body. Antipsychotics, which affects the hypothalamic thermoregulation. Benzodiazepines, because that reduces your awareness. You do not initiate behavioral responses of hypothermia. Beta blockers, because our physiological response to exposure to heat is blocked by beta blockers. Calcium channel blockers, diuretics, drugs of abuse, laxatives. Laxatives and diuretics actually increase risk of dehydration. Then lithium, serotonin, or serotonin reuptake inhibitors, thyroid agonists, and TCAs, tricyclic antidepressants. So when we prescribe these medications, or when we see patients who are already on these medications, you have to be a little cautious these days. So let's look at some clinical presentations. A 30-year-old Caucasian female on holiday in Sri Lanka visiting Anuradhapura presents to us with edema of the lower limbs. She has no other illnesses, otherwise well. She was just exposed to a hot environment and she's not an acclimatized person. So this is the classic presentation of heat edema. A 10-year-old schoolboy develops sweating, abdominal cramps, nausea around midday during sports meet practice. This is the classic presentation of heat exhaustion. An 85-year-old lady was brought in with altered mental status on a hot day. She was found in a sweltering house with a tin sheet roof. A 15-year-old boy collapses after 2 hours of physical training, becomes unconscious en route to the hospital. A 2-year-old infant, lethargic after accident, being left in a car during a hot day. This is the classic presentation of a heat stroke in your varying ages. So in countries where actual deaths from heat stroke is common, like America, like Australia, they have this little behavioral things. They use like a teddy bear in the car, and you remember to take the teddy bear with you. And like, if you leave the teddy bear, you know the kid is still in the car. You practice taking the teddy bear with you when you get down from the car. Right, then what do we do about these minor conditions? So minor conditions are the heat rashes like prickly heat. This is due to occlusion of sweat glands. Heat edema is a very benign self-limiting condition. It's usually only in lower limbs. It's due to hydrostatic pressure, vasodilatation, and vascular leak. You don't need to do anything for this. Heat cramps are a tiny bit, I would say, a little bit more serious. Now, heat cramps occur when there is relative electrolyte deficiency, particularly sodium. So this occurs either during or after exercise. Then this can progress into heat syncope, which is a form of orthostatic syncope, again secondary to cutaneous vasodilatation and venous pooling. So what do we do? For prickly heat rash, it's a bit itchy. So you could use calamine lotions, avoid sweating. You can use antihistamines and steroid creams. The most important thing is if you have prickly heat rashes, you could actually go for loose fitting clothing. Loose fitting, long sleeved clothing, they say, especially if the ambient UV exposure is high, we should encourage our population, our people, to wear long sleeved clothing. What about heat edema? You don't need to do anything. It's a self-limiting condition. You could use compression stockings. You could elevate legs, but diuretic use is counterproductive. You increase the risk of dehydration. So for edema, heat edema, we don't prescribe diuretics. And heat cramps, what do we do? Minimize exertion. We can start them on oral fluid and salt replacement. This can progress to heat syncope. If somebody collapses or develops syncope when they are in a hot environment, the first thing to do is remove them from the hot environment. Stop exertion. And the classical thing about heat syncope is they recover very fast, very quick to recover. You can start them on oral rehydration. However, these patients can progress into heat exhaustion. So heat exhaustion can occur either with normal or elevated core body temperature. They're usually tachycardic. They feel quite weak. They feel faintish, and they have nausea and vomiting. Very rarely, particularly exhaustion or particularly exercise-induced heat injury, exercise-induced heat exhaustion can have rhabdomyolysis, acute renal failure, and DIC as well. Not classically though. This is the commonest form of heat-related emergency that would come to the emergency department. What do we do? First thing to do is bring them down to a shady area, remove them from the hot environment, minimize exertion, and start hydration. Now, these patients actually may need IV hydration, and we might have to initiate cooling methods for these patients. What about heat stroke? This is a medical emergency. By definition, a heat stroke victim would have a core body temperature above 40 degrees centigrade or 104 degrees Fahrenheit associated with CNS dysfunction. What are the CNS dysfunctions that we consider? Even altered mentation, altered mental status is considered as a CNS dysfunction. Ataxia, irritability, dizziness, confusion, and coma. Also seizures. These patients, although not a part of the definition, can also have shock and coagulopathy. So heat stroke victims are at risk of multi-organ dysfunction and cardiac arrest. Heat stroke can be exertional or classic. Classic is where you have high ambient temperatures. The exertional heat stroke could be secondary to physical exertion or occupational exposures. It depends on the environment where you are. the use of gear, poor physical conditioning, presence of other medical illnesses, and lack of heat acclimatization. So as emergency physicians, our approach to any medical emergency is an ABCD approach. Most of the heat stroke patients will need some form of airway support because they have CNS dysfunction. This may be intubation. And even if we are going to use any form of airway support, it's always good to couple with it with benzodiazepine, particularly if when you're initiating cooling measures. It's a critically ill patient. You should start them on oxygen. We might consider non-invasive ventilation as well. We should initiate them on IV crystallite solutions, 1 to 2 liters per adult. For children, we actually go for 20 to 40 milliliters per kg. And we also use vasopressin. Right, then disability. Now I said heat stroke is by definition hypothermia plus CNS dysfunction. But heat stroke is not the only cause that can result in hypothermia and CNS dysfunction. There are so many other causes. A lot of other differential diagnoses are there, so we have to consider them. And in exposure, most important thing for a heat-related emergency is remove them from the hot environment and initiate cooling. If they've got evidence of heat stroke, initiate cooling on site. The target of cooling is to achieve a core body temperature of less than 38 degrees centigrade. So what are these differential diagnoses that we should consider? CNS infections, primary CNS disorders, endocrine emergencies like thyroid storm, toxicological causes like substance abuse, delirium tremens, neuroleptic malignant syndrome, and malignant hyperthermia. Do we need to investigate these patients? So we don't do anything for mild and moderate cases. Mild and moderate heat-related illnesses should settle with minimal interventions and a little bit of hydration. That hydration is also oral hydration and a period of observation. But for heat stroke, because they are at a higher risk of going into multi-organ dysfunction, we should initiate investigations. We should do a full panel of investigations, including counts, electrolytes, renal and liver functions, creatine kinase, because they're at a higher risk of rhabdomyolysis, coagulation markers, and urine analysis. And they might actually need a little bit more of imaging as well. So if you do an investigation, you should also know what you're expecting to see. So in full blood count, you would see evidence of hemoconcentration with raised hemoglobin. WBC count can go up, particularly if you've got another differential diagnosis like infection on board. Then pure heat stroke can result in a thrombocytopenia in about 3 days, not on the first day, but in about 3 days. You have a lot of electrolyte abnormalities associated with the dehydration and rhabdomyolysis. Renal function tests become abnormal. You see about 30% of heat stroke patients going into renal failure. Liver functions can become abnormal, ASTs, ALTs, and the LDH. Acute liver failure can occur in up to 50% of patients with heat stroke. And then your serum creatine kinase level is going to go up, particularly with rhabdomyolysis. Your coagulation studies are going to go haywire if you have heat stroke. And DI, the presence of DIC is actually a prognosticating factor. If you have DIC, it actually predicts mortality in heat stroke. Urine analysis will show evidence of dehydration. If you do an ECG, you are most likely to see sinus tachycardia, but you can also see dysrhythmias, particularly when you have metabolic abnormalities. Chest x-rays are mostly done to screen for other differential diagnoses, but you can see evidence of pulmonary edema when you have multi-organ dysfunction. Then CT brain should be done, particularly in elderly victims, because we have to differentiate heat stroke from intracranial pathology. lumbar puncture can be considered, right? So let's consider what we should do for management of heat stroke. So when you suspect heat stroke, cooling measures should be initiated immediately. Our target to cool is a core body temperature of 38 degrees. And what the studies have shown us is, for adults, the most effective method of cooling is immersion in cold water. The water temperature should be between 1 to 17 degrees of centigrade. This is the most effective way. Now, in a practical sense, we might not be able to do it in a hospital setup or even in a pre-hospital setup. The next best thing to do is initiate evaporation cooling. So you spray the person with cold water and keep them under a fan or under an air conditioner. We can also initiate supplemental cooling methods like cold IV fluids, cooling blankets, and ice packs. When we place ice packs, what the studies have shown is keeping ice packs on your cheeks, palms, and soles are supposed to be more effective than keeping the ice pack in your neck, groin, and axilla. When you spray water on a heat stroke victim, you should spray water all over the victim, actually. We should remove the victim from the hot environment, minimize exertion, and before initiating cooling methods, all the hot clothes should be removed. There is no place for antipyretics, and there is no proven benefit of using dantrolene in heat stroke. What about body cavity lavage? Again, we don't have any good evidence to support body cavity lavage. We don't have any good evidence to support anti-DIC therapies as well. All heat stroke victims should be admitted. Everyone needs to be monitored for end organ damage. Mortality from heat stroke is between 10 to 50%, and 20% develop permanent CNS damage. Patients with altered mental status, persistent hypertension, intubated for airway protection, or having coexisting indications why you can need ICU care. Other mild and moderate heat-related illnesses can be discharged home after a period of observation when they have symptomatic improvement. What about the children? These days, most of the schools are having their sports meet. So children, they produce more heat per kg than adults. They have, when you consider the surface area, younger children have a higher surface area to mass, and they absorb more environmental heat. This is not so much so for these older children and adolescents, but they suffer, these older children and adolescents in our country suffer from obesity and lack of fitness. Children essentially have a smaller absolute blood volume, and their heat dissipation is poor. They don't have the temperature gradient that we have. The core and skin temperature gradient is less evident in children. And for a given metabolic rate, their cardiac output is lower than adults. They have a less capacity, less ability to produce sweat, and they don't initiate behavioral responses on their own. And heat acclimatization takes a longer time in children. So children essentially are at a higher risk of heat-related injuries. When we consider the differential diagnosis in children, again, most of the conditions they share with adults, like sepsis, CNS conditions, but they can also have, children may also have hypothalamic dysfunctions and congenital CNS abnormalities. Then there are more, the other differential diagnosis we consider would be status, epilepticus, toxic overdoses, particularly salicylate toxicity, serotonin syndrome, neuroleptic malignant syndrome, thyroid storm, and malignant hypothermia. Hemorrhagic shock and encephalopathy syndrome is a very rare condition, but they can present with similar clinical features. So what should we do for kids? initiate cooling. For children, they say immersion cooling is not good. For adults, immersion cooling was the most effective method of cooling. For children, evaporation cooling is the best form of cooling. So you spray them with water and put them under a fan or an air conditioning. You could use ice packs and cooling blankets. When we manage children, we don't go for cold IV fluids. We give them room temperature IV fluids. And generally, the volume that we use is something like 20 to 40 milliliters per kilogram. But exertional heat stroke children may need volumes of up to 60 milliliters per kilogram. It's a large volume. One of the other things with kids is that they are at a higher risk of having over rapid cooling and overshoot of their temperature, like the temperature going down too rapidly. So we have to be aware how fast we cool them as well. Children particularly, when we initiate all these methods of cooling, especially if we use immersion method of cooling, they can start shivering. So when we manage heat-related injuries or heat stroke in kids, we give them benzodiazepines to stop shivering. Again, like in adults, antipyretics have no place, isopropyl alcohol baths have no place, and dantrolene has no place in the heat stroke management. All kids who develop heat stroke need critical care management. If you consider mortality, adolescents are at a lower risk of dying than elderly and the young. If somebody develops a core temperature more than 42 degrees centigrade, it is likely to result in permanent neurological damage. These permanent neurological damages are like spasticity, dysarthrias, ataxias, poor coordination, poor memory, and behavioral changes. So what can we do to prevent? Number one thing is avoid exertion and avoid being outdoors, particularly at the height of ambient high temperatures. Number two, the most modifiable thing is keeping up with your hydration. So you need to have hydration before activity and drink to thirst during activity. We can also empower the public and screen the at-risk groups. I told you at the beginning, the temperature reading is not the thermometer reading, but what it feels like. So wet bulb globe temperature index or the heat index is what we should check. Actually, in other countries, for occupational exposures, they need to show this. They need to actually show and ensure the safety of workers. So wet bulb globe temperature index is that you check the air temperature. You also, like 10% of the air temperature plus 70% of natural wet bulb temperature, which is something simulating the cooling effect of sweat, plus 20% of black globe temperature, which is how hot it feels in direct sunlight. So this equation gives you actually how it feels like. So that includes the actual temperature, the humidity, the wind speed, the sunlight, and gives you a reading of how much it feels like, right? So in other countries, they use the wet bulb globe temperature index to assess the environmental heat risk. And you can also go for heat acclimatization. If you can't avoid, you can also train to be at less risk of heat injury. 1 to 2 hours of exercise in a hot environment over a period of 2 weeks. The children have a less capacity to acclimatize them. And then as doctors, we prescribe, so we should be cautious when we prescribe medications. So athletes, now general population, preventive strategies are the ones that I've spoken about. For athletes, we can actually educate the administrators, the coaches, the teachers. We can encourage acclimatization. Now, we are a hot country. Our country situated near the equator. Essentially, we are a hot country. So we can actually encourage acclimatization among athletes to prevent deaths. And for outdoor workers, again, we can initiate better methods. Right, do you have any questions regarding heat-related illnesses? So you could use the rectal thermometer or the esophageal probe in the multipara monitor. Both are equally effective. Most of the multipara monitors that are being used, they do come with the esophageal thermometer probe, which can be used, or you can use the rectal thermometer, rectal temperature.
Generally, the thermometer is somewhere you can't find it.
So it's a tiny.
To find it and it attached to the monitor.
It's like a wire. It's not very big. It looks like a wire.
It's like a wire. Thermometer is a thermistor at the tip of the wire, so it is you have to ask nurses which self and keep it attached.
Sorry? Eardrum temperature is not considered as a core temperature. It's basically the skin temperature. Eardrum temperature is more like your skin temperature. So what they say is you shouldn't cool more, like the drop shouldn't be more than 0.1 degrees per minute. The drop should not be more than 0.1 degrees per minute.
1 degree per 10 minutes.
Per 10 minutes. But you have to certainly start it early. It is actually called rapid cooling, but not over rapid cooling, especially for children. I have a question for you, and we've just touched the heat-related emergencies. What about the UV index and the UV-related illnesses, UV-related problems that we face? Particularly countries like Australia, they have a high UV exposure. Even us, we have a very high UV index, but we don't behaviorally, we don't do much about it. We should be using, all of us should be using sunscreen with SPF over 45. Plus, we should use wide brims. At least we should teach our kids to use wide brimmed hats, not the baseball cap we commonly use. It should be either a bucket hat with a wide, or a Legionnaires hat, like a wide brimmed hat that we should be using. Also, our brown skin protects us against UV-induced skin cancers. Maybe that's why we are not so aware about these UV-related illnesses, but other countries, particularly the white people, they are more aware of UV-induced skin cancers.
Is the correct time to have sports meets in schools?
The first thing of prevention is first thing of prevention is to avoid being outdoors, particularly at the height of heat. So,
the time they have team matches and
yeah,
the
sports meet.
The first term.
And they also go out like between 10 and 12, when you have the highest temperature or highest sunlight exposure. Yeah, it's so I don't think we've had like any pure heat stroke induced deaths. I don't think we've ever like pure heat stroke causing deaths, but certainly you've got a lot of other things contributing, and heat is one of the things that contributed to deaths in the things that I've shown.